luck. Yeah. Thank you. It's really good to be here. It's great to be back in Durham. We're loving living here. There is one cruel irony, which is when I was a resident, you never get to see anything but your bed in the hospital. So I didn't have the time or the money to go to the to see the Duke Blue Devils play basketball, even though I could have gotten the tickets back then. The cruel irony is now I have the time and the money, but I can't get the tickets. I have to correct one thing. We don't use the, at least I don't use the R word in our house, the retirement word. I have plenty of good things to do. So it's just the next phase of having fun. So one thing, this institute, the Duke Global Health Institute, wasn't even a gleam in Mike Merson's eye or Chris Plow's eye when I was a family medicine resident. I don't remember what was here, I remember Pickens. And if you think about it, global health, most of what we use today in terms of vaccines, medicines, and other technologies didn't exist when your grandparents, or for some of us, our parents were born. It's been an amazing 50 years of achievement in all sorts of different ways. And there's a huge amount to be proud of. And Duke Global Health Institute has been a contributor in lots of different fields to achieve that progress. One of my mottos in life is never learn from only your own successes and failure. Life's too short. I originally called this Successes, Near Misses, and Failures, but then I was reminded of Jonas Salk, who said he never, he didn't have 200 failures on the way to polio vaccine. He just had 200 things that didn't work. So what we're going to talk about today is what moves global health agendas, and anchored in the overarching vision and goal of health, the right to health. Universal health coverage is a way to do that, and health systems, as strong health systems, is the platform. So those are sort of, for me, given for the rest of the talk. And we're going to focus on how science and innovation, leadership, and advocacy help us achieve global health impact. And we're going to focus on 3 examples. I'm a kind of, like a lot of people in global health, sort of a show-me person, wanting the examples and what's really happened in the field. So those are the 5 we picked. 3 of those are among WHO's top 10 threats to global health in 2019. So
today, the world celebrates the eradication of this dread disease.
Most of us know smallpox as a horrific disease. Killed maybe 1 out of 3 people, blinded and disfigured the rest, killed as many as 500 million people in the last century. And it was ravaging to societies and worldwide. So in 1966, the World Health Organization, the World Health Assembly, which is all of the ministers of health of the world, got together and they voted a smallpox eradication program. It lasted for a little over 11 years. It was supposed to last a decade. They went a little over. The last case was in 1978, and it was signed off as having been eradicated. This is the parchment that the committee signed on to say it's eradicated. Greatest achievement in public health, many say. So, success, near miss, or not yet? It was stunning to me to realize it was a near miss. It was a near miss. So the conversation, the map at the bottom is what the world smallpox epidemiology looked like around 1950. This is 59, a little different. So by 1950, Europe and North America had eradicated smallpox. The vaccine that Edward Jenner developed in the 1790s had gotten better and better, some of the techniques and all. So we were able to eradicate smallpox and here in North America and in Europe. So the head of the World Health Organization office for the Americas, PAHO, this is Dr. Sopa, said, let's do for the rest of the world what we've already proven is possible in Europe and North America. Dr. Chisholm, the first head of the World Health Organization, in 1953 said, let's do it, let's do it. It actually took 3 World Health Assemblies over 15 years before the world's health leaders voted to eradicate smallpox. And that vote, and one of the key people on the right there is D.A. Henderson, who I'll come back to, but talking to him, he was a key part of making this happen. That vote only passed by 2 votes. During the 15 years that they were talking, how many people do you think died from smallpox? 30 to 40 million people, mostly the poor and voiceless in Africa and Southeast Asia. And who do you think was the biggest opponent to smallpox eradication? One of the biggest opponents. It was Dr. Kandau. Dr. Kandau was the director of the World Health Organization who came in after Dr. Chisholm, the first director general. Dr. Kandau was a very good public health physician from Brazil. He was actually overseeing WHO's first effort at malaria eradication. But he knew he had a lot of indigenous Brazilians in the Amazon that they couldn't vaccinate. He couldn't imagine eradicating smallpox without vaccinating the entire planet. So it was the tenacity of people like D.A. Henderson, who was a physician at CDC and then at the World Health Organization, that actually helped break the lock, negotiated, really worked hard, was regularly chastised by his colleagues back in Atlanta at CDC when he was over there in the early years building the groundwork for it, but he made it happen. So a really good example of good science plus the right leadership.
Today, 15 million people are on life-saving HIV treatment.
So the first new human pandemic in modern times was AIDS. And after a decade of sort of a slow start, let's just look for a minute at what happened here. So we've got the new infections, which is AIDS, it would start in 1981, and new infections peaked out in the mid-90s and then started coming down. Deaths were continuing to increase. And then that line in 2000 was an amazing explosion of commitment to treatment, and we scaled up treatment. So there was a real outpouring, particularly in the 2000s, of great support for AIDS and AIDS response. And so if you look at that, what would you call that? Success? Near miss? Not yet?
Not yet.
Yeah, well, so this is an iconic picture some of you may have seen from Paul Farmer and Jim Kim's group, Partners in Health. This is a fellow, Joseph Jun, in the year 2000, and this is what he looked like with TB and AIDS. His family had already bought the coffin. This is the same person a few months later on treatment. That was the power of AIDS treatment, which just got developed in the late 90s as a result, in good measure, of AIDS activists banging on the door of the Food and Drug Administration to fast track and a bunch of different things to get treatment. So that sounds like a great thing and a real gift to the world. Not everybody reacted the same way. By the way, most global health things happen in shirt sleeves, so if you're okay with it, I'm going to dodge my coat. So, AIDS 2000, July, in Durban, South Africa. We've just been through a 3-year period when we saw the hospitals in Europe and North America emptied of AIDS patients. AIDS had been turned into a chronic disease where people on treatment would live almost as long with AIDS as they would have without treatment. It was stunning. But in July of 2000, AIDS was still a death sentence in Africa because there was based at $12,000 per person per year, no systems, no money, no treatment. So Sunday night, the opening, 12,000 of us there for the AIDS 2000. A wonderful indigenous dancers get it started. And then the fellow in the middle, anybody recognize the fellow in the middle? Cheryl for sure recognizes it. This is President Thabo Mbeki from South Africa. So he gets up with all these people who understand what's happening in the world, and he basically says that AIDS treatment is a pharmaceutical company CIA plot, and he's not going to treat people in South Africa with antiretrovirals. The next morning, the fellow on the right, Edwin Cameron, who is the only self-declared HIV-positive high court judge in Africa, Edwin Cameron gets up and basically says, this is immoral, we need treatment, and no two ways about it. While that's happening inside, the fellow in the middle there with the HIV t-shirt, Zaki Ahmed, who became the face of the Treatment Action Coalition, and the activists, they're demonstrating in the streets for the drugs. And so that was a situation not too long ago, the year 2000. And the image of Zaki Ahmed and the Treatment Action Coalition was riveted in my mind, and we would regularly have a sort of a conspiracy where we'd meet and get their points of view, but then they'd go in public and trash our program, or Peter P.I. had the UNAIDS, which is a way of provoking their supporters to come back and support the people like the head of UNAIDS. So, working on this book, The End of Epidemics, I met with, had the opportunity in South Africa to meet with Justice Cameron, and who had he's been HIV positive for 30 years and on antiretrovirals for 18, and had just finished a 96-mile bike marathon that Sunday. Amazing guy. So I was saying how impressed I was with Zaki Ahmed and all that, and he says, you need to understand the whole story. And so what came out was a four-part strategy that they had. And let me say, the denialism of Thabo Mbeki cost South Africa at least 350,000 lives. Most people who've been in the region say 500,000 lives. And so that's what they were fighting. That's what Treatment Action Coalition. So they had a four-part strategy. Part one was evidence. I'd actually never thought about it. I mean, part one was evidence. They wanted to be sure that their activism was grounded. Part two was mobilization, getting the communities involved. Part three was media, and part four was the legal strategy. And it was, in the end, a legal strategy, very well-chosen cases that got the treatment there. So I asked, I said, well, why didn't they just go to the legal strategy? It was really interesting. The answer was, if we went to the legal strategy, it wouldn't have been implemented, because the people in power wouldn't have done it. But because we had the people on our side, the communities, that alone, getting the communities, they had the communities on their side, but they weren't getting treatment. Once they had that and the legal case, and interestingly, we've got a group of under 20s suing the U.S. government over global warming, and they're actually moving things through the court well. So basically, the AIDS response, and I'm really, I'm looking at Cheryl, I'm really shortening this, but it was a series of remarkable journeys and successes in science, leadership, and advocacy. But it was punctuated by what I would call 3 points of deadly negligence. The first was in the first few years, where we basically had in the mid-'80s, we had a standoff between the right, when people were saying that, this was the wrath of God and we're not going to respond to this gay population, all that. But on the other side, with the gay community, they were so distrustful, they were resisting basic public health measures. So that was one deadly negligence. The other, AIDS denialism, that was the Mbeki thing, which we got past. We're now at a point where the question now, we're on the verge of being able to eliminate AIDS as a public health threat. And the question now is, are we going to maintain or lose momentum because of AIDS fatigue. And in essence, are we going to win or lose the war on AIDS? And these are sort of two scenarios. And the fellow who worked through this scenario was so concerned that he wanted to give a sense of how we would feel in 2030. So this is a trailer. I want to show you a trailer for a film we hope won't be made. You can see that. That's 2030 in Durban, same place.
Imagine the keepers of history looking at us all, seeing the remarkable global response to the AIDS crisis in the early years of the 21st century, and seeing that we threw it all away so quickly, and now, in 2030, wondering why we failed.
The AIDS epidemic is now 50 years old. At one point, we thought we were going to win the war. But now AIDS has come back worse than ever.
62 million people have died. Within a few years, the war against AIDS will become the deadliest war in human history.
My brother was a beautiful spirit. When he died, we held a celebration. We celebrated him, his life, his music.
We were not helpless. We were not unarmed. We were not without science.
The crucial years were between 2015 and 2020. That was when the global response to AIDS started to collapse. And obviously, the collapse meant that many people could no longer get treatment.
My father dedicated his life to helping people, but he died a few years after the supply of medications ran out. Such a waste.
It's shocking how many opportunities we miss, like needle exchange programs.
What really angers me is what happened to young girls. We had that great PEPFAR program, but it only lasted a few years.
My daughter was a beautiful girl. I couldn't stand to see her shrivel up and die.
We come, we cry, we console, we remember, and then the world leaves us to our grief.
May the spirits of those who died forgive us. May the families of those who died forgive us. History may forgive us, but I promise you, history will never forget us.
Since that trailer was made, there's been a number of good steps forward, and we're still the end is still not inevitable. And one thing on needle exchange, one of the characteristics of the U.S. AIDS epidemic is, many of you know, is it moved from a sort of a kind of a West Coast gay population to a Southeast drug using and impoverished population, and the variation in state laws on drug exchange, needle exchange was one of the factors in that.
Today, the World Health Organization can say that the SARS outbreaks have been contained worldwide. So,
the first new human pathogen of the 21st century was SARS, a coronavirus that came out of rural China from a bat to a civet, which is a delicacy meat in China, to somebody who ate that in rural China, to a Chinese doctor who treated that patient, to the 7th floor of the Metropole Hotel. And what you see there is the floor plan of that 7th floor wing. And from that one person who is there in dark on the right, it got to a dozen or more people. And from there, within a matter of weeks, it got to 27 countries worldwide. One of those countries was Canada. Another one, there were several in the region, of course, got to Latin America. So that started right at the beginning of 2003. And it was in China. China was hiding it. They were just plain hiding it. Canada had developed a new tool to scan the news reports. They developed it after there was a plague epidemic in India in the 1990s that CNN was the first to report. The government of India, they probably didn't know, but certainly didn't admit it. So WHO got a call from Public Health Canada saying, something's funny going on in China. You got to figure it out. So WHO, with great effort, sent out a team. And on a Saturday in mid-March, the Director General of the World Health Organization, then Gro Harlem Brundtland, the former Prime Minister of Norway, she'd been Prime Minister at a young age, she got a call from the team there, or her head of communicable disease. And so there was a guy named Dr. Heyman, who some of you know. So the head of communicable disease and the Director General got together on this Saturday, and within 4 hours, Dr. Brundtland was presented with 2 bits of information. This is a new disease that's killing health workers. That's a canary in the coal mine for new, and it's crossing borders. So without consulting anybody, she called the highest level of travel alert she could at the time. That actually infuriated the mayor of Toronto because they had some of the cases. He had no idea what the World Health Organization was, but he did know that it was canceling Elton John concerts and ravaging the economy. But they stopped it. By June of that year, it was eliminated. So in April of that year, the head of the CDC was in Hong Kong and said, "Do you think we can get rid of this SARS, this new thing will go away?" And he said, "No, I don't think so. We can get it to low level." But by June, Hong Kong was declared SARS-free. So that was an example of success, near miss, or not yet. So that, by the way, was it a dodged bullet? Because that outbreak was within a few plane rides of getting into countries that couldn't have put it back in the box. And one of the key things was rapid mobilization of the scientific community. Within a few weeks after getting the first samples, they were out to scientific institutions who were able to identify it, were able to get the necessary information to do the diagnostics. So it was a success. It hasn't returned, but it was a dodged bullet because it could be still with us today if we hadn't been more vigilant. So that's an example of, I think, really good leadership. And 2 things that set us up for that. One was building the groundwork of a global response network. Another was having that surveillance. And this network was something that that WHO had invested in building over the years between 1998 and 2003. And then that rapid action. And I asked Dr. Brundtland, I said, what made you decide to invest in building the infectious disease capability? And she said it quite simply, they made the case. She was a very evidence-based decision maker. So let me give you sort of the other example, because I want to show that what happens when things don't quite work. The other 2 people up there, Dr. Joanne Liu is a pediatrician who's president of MSF Worldwide, and Dr. Margaret Chan is a public health physician who was Director General. All 3 of the people up there are very accomplished professionals. It was the first outbreak of the West Africa Ebola outbreak, the first cases of the West Africa Ebola epidemic were in December of 2013. And beginning in February and March, MSF, Doctors Without Borders, was seeing something was wrong. And Dr. Liu kept trying to raise the alarm over 4 months. Finally, it was only when 2 ex-workers were brought out to Europe and North America, 2 American health workers were brought back to Atlanta, and it hit the global headlines. And there was this panic, and it literally set Twitter records. WHO finally took action. So the difference in leadership styles of decisiveness and rapid action versus a more sort of collaborative, consultative, and really taking the alarm when it hits. Okay, on to measles. It's stunning. We all know the power of vaccine, but sometimes we forget. Measles vaccine was first available in the 1960s. And before that, that was the annual worldwide deaths from measles. Today, it's about 110,000, so a fraction of what it was. And by WHO calculations, 21 million deaths have been averted between 2000 and 2017 just from measles immunization. And actually, by the year 2000, the US and a number of other countries had eliminated measles. We had had a year without any indigenous person-to-person transition. But then something started happening, and we started having outbreaks of measles in a variety of different places. The picture there is from this outbreak in Minnesota, which came out of a Somali population. And we began losing grounds. This was as a result of a movement that had been gaining momentum over time. I would say measles is and not yet. And we're hitting a point where the long tail of junk science and junk news is catching up with us. How many people know the name Andrew Wakefield? Okay, yeah, a big groan. So I think this is, for people who know of Wakefield, you're tired of the story, but actually it's a stunning story. So so what we have here is a time series of immunization against measles in the United Kingdom. Got introduced in the 80s. They were getting close in a matter of 6 years to 95%, which is what you need. Because measles is so infectious, you need much higher immunization coverage to get the herd effect. Then Wakefield, who was a gastroenterologist researcher, with 12 other folks, published this article in which they made an inference that measles vaccine caused autism. Now, what's interesting is it brought it down in the first year, but then it leveled off. What was happening was that the tabloid media and then the mainstream media was getting on board with Wakefield because it was a big scientific, a lot of the, not surprisingly, the mainstream community was hammering at Wakefield for this as soon as it came out, for making this inference, because they knew what would happen with measles, and they knew there was no evidence. So then it went plummeting down. Finally, Brian Deere, a really good investigative journalist, got the truth that Wakefield had a vested interest in autism. He was hooked up with a lawyer. The article wasn't that strong. There were all sorts of conflicts of interest and everything else. So he published that article. The mainstream media started doing mea culpas and communicating and getting it on board, and getting on board with bringing the immunization rate back up. And then the efforts that the government had been doing, which they had started to try to do something, but that alone, because the people weren't with them, that didn't have an effect until the truth got out there. And in fact, the Lancet finally retracted the article 12 years after it was published. In the question and answer, we can talk about the conversation with Richard Orton about that, the editor of the Lancet. But so that started the vaccine autism myth. And good. So UK got back there, but what this started was a point source epidemic of fake science going everywhere. And this is a map by colleagues at the London School of Hygiene and Tropical Medicine, Heidi Larson, who runs the Vaccine Confidence Group. And it's stunning how this fake science has gone worldwide. So how is that happening? So I have to say, and this was a big aha several months ago, I realized that the anti-vax advocacy is a textbook example of how to do advocacy. Not in the right cause. A simple emotive message. Measles vaccine causes autism. That's going to get people upset. A charismatic, quote, credible, a leader and spokesperson. I mean, that was really a key part of it. Villains. Targeting naive populations like the Somali refugees who being convinced not to take the vaccine caused Minnesota's biggest outbreak in a long time. And then the whole kind of star power, political connectedness. Wakefield was at the inauguration of our current president. Ideologic allies, Italy, which had been pretty close to eliminating measles, has at least 5,000 cases last year because of a populist government that said, "Oh, it's up to you." And then Google capture. 3 or 4 years ago, if you Googled vaccine safety or vaccine effectiveness, your first screen would be full of the anti-vaxxer stuff. And that's a whole tale about how it's changed a lot now, a lot because of the work of Heidi Larson, who I mentioned, and so forth. So if we think then about how do we counter vaccine hesitancy, unfortunately, it's not. And these lessons are not just applying to vaccines. They're applying to other sorts of health behaviors. First of all, being clear what's at stake, because there's that generalization over to other vaccines. 20% of millennials in the country believe the vaccine autism myth. And when we did have a swine flu a few years ago, their rate of usage of swine flu in the 2009, quite a while before the millennials would have been involved. But the youth back then did not take up on the vaccine. So what's at stake is the bleed over to other vaccines, including the HPV vaccine and the influenza vaccines. Empathetic listening, being clear with the messages. Our messages around influenza are really muddled. Beware the backfire effect. There's an interesting dynamic which was first proven with politics, that and now we know in various areas, including this area, when you present somebody who, if you have somebody who's firmly attached to a belief, not just intellectually attached, but emotionally attached to a belief, and you present them with contrary evidence, solid evidence from good sources, they hold even tighter to that belief. And so the thing is, it's not the message, it's the messenger in those cases. And so that's why trusted messages. The success story that hasn't gotten told from West Africa, the first part about the outbreak and Ebola taking off and the disaster of the health systems, that's a story the West got that is a lot true. What's not told is how quickly Ebola subsided once in a country like Sierra Leone, you got the 4,000 market women, the 20,000 traditional healers, the religious community, everybody on board. So the trust is really important. That's why peer-based sharing, mother to mother, teen to teen, teens now who have grown up in anti-vax households and are actually concerned, are networking to sort of see how they can have the conversation. State and local requirements, and so forth. So there's a lot in trying to, once you've got sort of contrarian advocacy and an embedded message, it's a lot to turn that around. Okay, so speaking of influenza, you're probably tired of hearing this. Last year was the 1918. We've probably all been to events. It came right in the tail end of World War I. Where the virus came from is still a matter of some debate, but clearly the biggest seeding of the epidemic came out of Kansas, and we were sending troop carriers over, literally with bodies in their wake, as part of getting it started. But at the same time, we learned a lot about how we use non-pharmacologic, non-vaccine measures to control the epidemic. The bottom curve is this famous W curve. It's a curve, you don't need to see the details of it, but basically, that's the young, that's the old. This is that's the children, that's the old, and that's the sort of healthy adults that we think of, and that's one of the characteristics of flu. So. We're just as vulnerable today, but for different reasons. And this is a modeling exercise, I will say a conservative modeling exercise that Bill Gates did with disease modeling folks. So this is what, if we had a flu virus like the one in 1918, highly contagious, highly deadly, something that most of us aren't used to, in 100 days, it killed 770,000 people. That's like a really bad seasonal flu worldwide. In 200 days, it would kill as many people as the first 3 decades of AIDS. That's the power. So you'd think that we would be prepared. The economic impact is huge. This is analysis that was done by the former Secretary of Treasury, Larry Summers, and he has looked at the data on this and said he's looked at global threats and he said the balance between action and risk. He's never seen anything where there's as little relative action as there is risk. So this is definitely a big not yet. And influenza is a tricky virus, and it's something that's really hard for the public to understand. They don't know why it's not like measles, one and done, or other things. And the reality is it's a family of virus, it travels with packs, it's constantly mutating. And so this is the time series of the effectiveness. I think probably for last year, or 17, 18, it was maybe 30%. So that's not a great vaccine, and it's nowhere close to what you need in terms of effectiveness to stop an epidemic. So why, with one of the biggest pandemic threats, do we have basically the least effective commonly used vaccine? And it's strange. Spell checker didn't get that. The Spanish flu. The first vaccine was 1938. Jonas Salk actually got his chops for polio, developing the first polio vaccine that was used in troops. We've had a whole string of flu epidemics, all of which were relatively small. Finally, in The Lancet, a really tenacious epidemiologist looked at the data and said, wait a second. Once they looked at all the data, they said, we knew the vaccine wasn't so good, but it's even worse than we thought. What you saw was the adjusted ones. And published an analysis of that. Interestingly, he got hammered by the vaccine people just the way Wakefield did. The difference is he ended up being right. So that was 12. And then finally, probably catalyzed by 2018, we now have a strategy for universal flu vaccine, which is something that would get all of the different, a large share of the vaccines and make us much safer. We have one of the senators, Senator Ed Markey from Massachusetts, introduced a bill. The guy who did this article said it would cost $1 billion a year to invest in flu vaccines. So now we actually have, the result is that we have scores of promising vaccine concepts and more than a dozen clinical trials in progress. So why, after 100 years and 80 years of the vaccine, don't we have it? I think part of it is this influenza Ebola paradox. As I talked about earlier, Ebola set Twitter records. I mean, there was this horror factor which got everybody alert. when we got the headline that over 80,000 Americans had died, not just the young and the old, but the healthy weightlifters, marathon runners, that was like overshadowed by a bunch of other bits of news. So I think that's a factor. Economics is clearly a factor because the seasonal flu is predictive. It's a predictable market. And I think just some plain leadership gaps of being distracted on other priorities and not really stepping back and focusing at the big picture. So I'm just going to give one little plug for the book. By the way, I don't get anything from book sales. They go to Management Sciences for Health. But I do really believe that we can make the world a whole lot safer and try to put it in digestible ways. I guess the most positive indication that it may be digestible is that I did a class at, there's a wonderful teacher over at Carborough High, and talked to one of the sophomores there who had no problem with the book, and Laurie Garrett, who's wrote The Coming Plague, had no problem with it in her Lancet review, so hopefully it's of some use. To kind of bring this to an end, we have achieved the impossible in global health, in the sense that Ken Dow said eradicating smallpox was impossible. It happened. There were people who, including the head of the U.S. Agency for International Development, who in July 2000 said, "We're not going to do treatment in Africa. We don't think it's going to work." And the person who stood in Hong Kong and said, "I don't think SARS is ever going to go away." I think in terms of science and innovation, we've really seen the threats of bad science, but how fundamental good science is. With leadership, we've seen what happens when you get contrarian leadership, like we had with Thabo Mbeki or the anti-vax movement, but how courageous leaders like Gro Brundtland and Joanne Liu and many, many others, in the scientific community, the public community, and advocacy, contrarian advocacy, it can be deadly, but it was activists that crashed all the barriers to get AIDS prevention or treatment going and propelled a lot of other movements. So when I was a kid, we thought a lot about going to the moon, and Neil Armstrong, who landed on the moon, tells a story. So Kennedy said, "We're going to go to the moon in a decade." And this is the part I like. And send a human to the moon in a decade and bring them safely back to Earth. And I thought that last phrase was key. But they hit so many blocks. When he made that statement, there was no technology to get there. And the engineers, this is the Neil Armstrong story, the engineers kept going to the head of the project and said, "It's impossible, we can't do that." And the answer was, "We're going to the moon." And he kept going, the answer is, "We're going to the moon." The other story is a congressional committee that was visiting, and they saw a guy in the corner that was just sort of doing some stuff. He was sweeping and all. And the guy asked, "What are you doing?" And the guy said, "I'm getting a man to the moon." Mm-hmm. And the whole idea that we're all, wherever we are, whatever we're doing, we can connect ourselves through a very small number of dots to saving lives and improving health in the countries we're working in. And I think that's really the exciting part of global health. We have a couple of more epidemics to end. Malaria is one. Chris is helping on that one, and a few more where it's possible. We're not going to eradicate like smallpox, where the virus is gone, hopefully forever, but we're going to eliminate it as a public health problem. Number of different, we're part of a great community, and I know many of you are getting ready, or some of you, to go off to the consortiums of the universities in global health. But lots of, it's just a great community. Oops, that's still there again. So thank you, and I'm open for any questions that you have. Thank you for listening.
Thank you. My name is Pramod. So I lived in Africa for 21 years and worked for global health, worked for the Harvard AIDS Institute. And it's more like a comment. So I personally witnessed what you just mentioned, that how the Thabo Mbeki denied and how many people died. And on the contrary, Botswana, which was a neighboring country, they took all the health initiative. They collaborated with all the World Organization, and particularly because I was working for Harvard School of Public Health. And that time, the Botswana was the epicenter of HIV epidemic. And more than 40% kids were born with the HIV virus. And every village will have more than 10 to 15 funerals every week, you know. And it was really worrisome situation. And all this...
In those stories are from everywhere, and the orphans. And one of the indirect indicators was when you would be going out the road from a capital city or someplace, and you didn't see coffins for sale everywhere. Questions? Yeah.
You mentioned David Heyman, who was the head of infectious diseases. Some years ago, I heard him give a talk. The problem is, I've forgotten what he said, but it was amazing. He said something like, smallpox was a massive near miss in another way, because, like, very shortly after smallpox was eradicated, the first cases of HIV appeared. And if they had overlapped, we would never have been able to eradicate smallpox. I can't remember why. Why would we not have been able to eradicate smallpox in an era of HIV?
My hypothesis is because the vaccine wouldn't work.
That's what he said. Yeah, the vaccine wouldn't have worked.
Yeah, very
so that's
interesting.
an amazing. I mean, it was like I think when was smallpox eradicated?
78 was the last
78,
case.
and the first cases appeared in 1981.
Well, yeah.
So I mean, really.
Well, actually, truth be told, I mean they did overlap. Because if you, I didn't go through it, but we now know that AIDS came out of Southeast Cameroon, probably bushmeat, worked its way down to Kinshasa, and what happened was that was when it was the Belgian Congo. The Belgians didn't want to capacitate the Congolese, so they brought in Haitian guest workers. At the time of independence, they sent back the guest workers, and it was that's how AIDS got to Haiti. So. In the 70s, what David didn't tell you, but he does say, in the 70s, Uganda had something called wasting disease, which was probably, early AIDS. So, but we dodged a bullet on that for sure, because even if, Randy.
John, wonderful talk, thank you. I have to ask the question about the Deere article and the 10-year delay until Lancet retracted the Wakefield study.
Yeah, so... so what happened was that as soon as Deere's article came out, 10 of the 12 authors issued, and I love this term, a retraction of interpretation. And that's what the Lancet published. And it is really marble-mouthed. So at that time, retraction of interpretation, Richard Horton, the editor of Lancet, wrote a pretty long thing about, I don't know, it was a kind of a soft defense of Wakefield. But what happened, so the question I put to Richard was, why wait so long? And they were waiting, but basically the answer was due process. Innocent until proven guilty. And it was only when the medical council had all of the evidence that it was fraud and everything else, and as soon as they issued that, the Lancet retracted. So the answer was due process. The question I had which I accept that for the times, but now where junk science and junk news can combine to create such a mess, I think we need to figure out how to balance due process with primum non nocere, first do no harm. And I don't think we got that figured out yet. Yeah, Scott.
Yeah, thanks, Jono. I just wonder if you could say something about action or alert fatigue and how advocacy might do something about it. I was in Guinea, the tail end of the Ebola. For 3 months, I was embedded in the ministry. And even then, Ebola was still active. It was a couple months again until it was declared eradicated or completed there. And you'd go to the buckets, in front of everything. And even in the 3 months I was there, I went from seeing them out in front of every place with soap to some of them missing, to some of them having no water, and everything else. And the way people would talk about it and everything. Again, not much was happening in Conakry. But even in that short period of time, with so much going on and Sierra Leone still, in full force and everything else, you were already starting to see locally fatigue about something as emotional as Ebola.
And when you say fatigue, they weren't practicing the health.
They weren't practicing, yeah.
Well, a part of it is making the judgment. What are the health habits that you take during an epidemic, and what are the health habits you do all the time? But you get that. It's the complacency. It's the cycle of panic and complacency. And I can give example after example about things that took much longer than they should have because people got complacent and nobody was holding them accountable.
What can you do to
well,
keep it?
Part of it, well, first of all, it's flagging the issue and figuring out in whose interest is it to get stuff done and to realize that people do things for their reasons, not your reasons. So Groot-Brundtland did SARS, was convinced about that from evidence. The people who looked at it are pretty clear. George Bush, George W. Bush, even though he got started on AIDS for political reasons, it was a moral decision in the end. And so we got to figure out whether the business communities, in whose interest it is to keep an eye on it. And then when you've got something, which we have now, an accountability mechanism to make sure folks are keeping their promises. Yeah.
I'm Nebo Nangani from Moi University in Kenya.
Okay.
I arrived last night, so you'll excuse me if I'm not very articulate. Still jet lagged. I'm very happy and appreciate your focus on looking at SARS innovation and leadership and advocacy. The reason I'm here is to try and establish a center of excellence in leadership and governance for strengthening our devolved health system. I'm just reflecting on your leadership at MSH, where you have the challenge model that weaves leadership, management, and governance.
Yeah.
But here you seem to focus on leadership. Are you suggesting that governance and management are not?
Yeah, couldn't do everything.
Because
well, thank you for that. So what the leadership model you're talking about, we often try to develop leaders by pulling them out of their institution, putting them in class for a few weeks and sending them back. That doesn't usually change things. But leaders develop in their own workplace over time in teams by facing real challenges. And that was that model. And so you got to have managers who will lead and leaders who will govern. So yes, I mean governance is a big part of it, and accountability. And that's basically, although I called it leadership, Thabo Mbeki, who's the president of the country, that was catastrophic failure of governance. And those in government who knew he was off track weren't able to win. Do you have? I'm good. There was another question? Yeah.
John, that was a great talk. So do you have a perspective on climate change as a threat to global health?
Oh, yesterday, I'm smiling because yesterday we had a fabulous presentation by Professor Berry from Stanford on that. Absolutely, and particularly as it turns out, cities are amplifiers in a lot of ways. But yeah, no, it's huge. It's huge. It's huge for pandemics. It's huge for nutritional issues. I mean, calorie dense diets. It's just is that presentation on the web? Because that was a really concise.
It will be.
Will be?
Yeah.
So that was the Victor Zhao talk, lecture yesterday. It was fabulous. So it's it's easy to just sort of, you don't even have to listen to it. It's very clear.
Check back on the DGHI YouTube channel in a couple weeks.
Yeah.
Thanks for your talk. I had a follow-up question to the climate change question. So from your vast experience in advocacy and in the realm of global health, what suggestions do you have? Because I think a lot of people have criticisms of our field in that we're not pushing the climate change agenda and articulating a big enough vision that has actionable steps for us to take right now as professionals. So I'd love to get your opinion.
So the first bit of the opinion is to watch the video. But one of the things that came out yesterday was we've evolved from tropical medicine to international health to global health. And the prediction was maybe we're going to evolve to planetary health. Well, we've got that in our reflexes. And I think there's a great health. Well, this is on the urban side. A health initiative called Healthy Cities, which is very active in Southeast Asia. But I mean, it's just so broad. I'd be hard pressed to recommend one thing. Probably the key thing is to figure out pretty much take the assumption whatever your interest is and whatever your skill set is, there's probably a connection with climate. And you work best when you work in a place of sort of knowledge and passion. So if you can figure out where that intersection is and just really figure out who's doing what in that area. So if you're an epidemiologist, see how that people doing epidemiology in relation, and there's great epidemiology in relation to climate change and the impact, and then you can take that to the action side.
We are out of time.
Okay.
But thank you so much.
Thank you very much.